If you have rotator cuff related shoulder pain, the honest summary of the exercise evidence is that the type of exercise matters less than most programs imply. When researchers pooled 22 randomized controlled trials, one type of program probably did reduce disability slightly more than another on moderate certainty evidence. It did not significantly reduce pain in the short term. That split is the finding that is rarely explained to patients. Let me tell you what the review actually did, because the design matters. This was a systematic review with meta-analyses. It covered 22 randomized controlled trials and 1,281 adults with rotator cuff-related shoulder pain. The authors organized the evidence by the FITT principle. That stands for frequency, intensity, type, and time. The idea was to ask, variable by variable, which of those four things the evidence can actually speak to. Separate meta-analyses compared exercise type, meaning specific versus non-specific programs, and exercise intensity, meaning high versus low. The certainty of each finding was rated using grade, which is a formal system for saying how much confidence a body of evidence deserves. Start with type. Motor control exercise programs significantly reduce disability compared with non-specific programs in the short term. The pooled effect was a standardized mean difference of minus 0.29, which is a small effect, and it came from 323 participants across 7 trials. In the medium term, the picture held with a slightly larger but still small effect drawn from 286 participants across 5 trials. The certainty on that disability finding was rated moderate. Now, the part that surprises people: pain in the short term did not differ significantly between motor control programs and non-specific programs. The pooled estimate leaned slightly in favor of motor control exercise, but the range of plausible values crossed 0, which means the trials cannot rule out no difference at all. So you have a program type that probably helps how well the shoulder functions and does not clearly help how much the shoulder hurts, at least not in the short term. If your function is improved and your pain has not, that is consistent with the evidence. The pooled trials found a significant improvement in disability and no significant short-term difference in pain between exercise types. Function and pain are separate outcomes, and they can move at different rates. What about the other kinds of exercise you may have been prescribed? Uncertainty remained for eccentric programs and for scapula-focused programs, compared with non-specific exercise. The evidence there was low to very low certainty. That is not the same as saying they do not work. It means the evidence is not strong enough to tell you much either way. And uncertainty is the honest description of where those comparisons stand. Intensity is the same story. The evidence comparing higher intensity with lower intensity was low to very low certainty. And then there's the finding that says the most about the state of this field. No trials were identified that compared different frequencies at all. None compared different session times. Not weak trials, no trials. So if you have been told that a specific number of sets, a specific number of repetitions, or a specific number of sessions per week is the correct prescription, that number is not coming from comparative trial evidence. It may still be perfectly reasonable, but it is convention rather than proof. And it is worth knowing which one you are being handed. If you want to know how many sessions a week you should be doing, that is a question to discuss with whoever is supervising your program, because no trial has answered it. Here is how the authors summarized it. For adults with rotator cuff-related shoulder pain, motor control exercise programs were probably slightly superior to non-specific exercise programs. Then they added a caveat that is arguably the most practical sentence in the paper. It is unclear whether the effects were due to motor control exercise itself or to other program characteristics, such as progression and tailoring. Sit with that for a moment. A program that gets harder as you get stronger and that is adapted to you rather than handed to you off a shelf may be doing the work. Regardless of what the exercises are called, the label on the program may be the least important thing about it. Exercise is the first line for this problem, but it is not the only question. Where symptoms do not follow the expected course, establishing what is actually generating the pain still matters. Image guidance allows an injection to be placed in a confirmed location rather than approximately. At Padda Institute, the relevant pages are ultrasound-guided and fluoroscopic procedures, shockwave therapy, and hydrodissection. 2 other things are worth separating out. Where shoulder pain coexists with neck symptoms, telling the two apart matters because the distinction changes treatment entirely. And where trigger points in the shoulder girdle contribute, that is a separate conversation with its own evidence base.